Hey guys, good morning. I'm going to go over some of the respiratory structure and pre-lab learning for respiratory system. So here I will talk about the anatomy of the respiratory system and then some mechanics of breathing, exchange of gases across the lungs, and then some of the disease which is associated with the respiratory system like uh, obstructive and restrictive lung disorders. Okay, so respiratory system structure is divided into two groups: upper respiratory tract and lower respiratory tract. So you can see here in this diagram from the nose and nasal cavity, pharynx, glottis, and the larynx up to the larynx, that is upper respiratory tract. From trachea, then the lungs, and inside the lungs you have primary, secondary, tertiary, and several branching of the bronchi and bronchioles, along with the diaphragm, are the lower respiratory tract structure. Okay, so this is the organs of the respiratory system. So when we inhale air rich in oxygen from the nose and sometimes from the mouth, it enters your pharynx, then larynx, and trachea, then enters our lungs, and in the lungs it enters ultimately the smallest unit of our lung, that is the alveolus, where the oxygen diffuse from the alveolus into our pulmonary capillaries and then carried back to the heart and all over the body, whereas carbon dioxide from the pulmonary capillaries diffuse into the alveoli and then that is exhaled through your nose during the exhalation. That's how our respiratory system works. Okay. Uh, to measure how our lungs are functioning, how our respiratory tract is functioning, we do several the measurements of lung volumes and lung capacities. So here, this is the graph of the lung capacities. Okay, and I'm going to go over them in a while, but here, so this is the graph. You see, uh, the uh, respiratory therapist put the respirator in your mouth and then ask you to breathe in and breathe out, and then the flow of air is measured through a pointer which makes the graph on the graph paper, and here is the graph. So you see this black line, this is the time here, and this is the lung volume. So you see when you inhale, you have here around 500 ml, and then you exhale, inhale, exhale, inhale, exhale. So this volume you see here, every time normally at rest when you inhale or exhale, that normal volume is called tidal volume. Okay, that's called tidal volume. And then with force you can add. So let's see, I'm inhaling here, exhaling, and then I inhale up to here, up to this line, which is the 500 ml. And then with force, when I inhale more, I can inhale up to here 6,000 ml. So from this 500 ml, this line, everything here is the inspiratory reserve volume. Okay, that is inspiratory reserve volume. So if we add this tidal volume and the inspiratory reserve volume, that volume is called inspiratory capacity. So if you add if you add two or more than two the respiratory volumes, that becomes the respiratory capacity. That's why you have tidal volume, inspiratory reserve volume, and if you add them together, we call it inspiratory capacity. Okay, let's go here another here. So again, tidal volume, And then we exhale 500 ml, which is tidal volume. And then we force, we can exhale more. And that extra, whatever we exhale on tidal expiration, that is called expiratory reserve volume. And if we add tidal volume with the, so you have here, this is the inspiratory capacity, expiratory capacity here. So my question is, if I exhale air with force, can I exhale all the air in my lungs? No, there will be some amount. So if I add expiratory reserve volume here on this one, and then the residual volume, this together is called functional residual capacity. This volume in some patient increase or decrease based on what kind of respiratory problem you have. Now, if you add the functional residual capacity and then the vital capacity, inspiratory capacity together. So functional residual capacity and inspiratory capacity together, we call them vital capacity. And if you add all the volumes together, we call it total lung capacity. And they are abbreviated here, you can see them. Obstructive versus restrictive lung disorder. So when flow of air during inspiration or expiration is reduced, that condition is called obstructive lung disorder. When the volume of your lungs has decreased due to any disease, that disease is called restrictive lung disorder. So every time when the airflow is obstructed, that is called obstructive disease. But let's see if you have the problem with your rib cage or respiratory muscle or your diaphragm, and you cannot inhale enough amount. That means your volume of the lungs is restricted, and that is called restrictive lung disorder. Some example of obstructive lung disorder are like bronchial asthma. Restrictive lung disorders are like the lung fibrosis or neuromuscular disorders of your chest muscles or bones. Okay. COPD is chronic obstructive pulmonary disease, which is the chronic bronchitis and the emphysema and bronchial asthma. Together, these all we call them COPD, and they are obstructive lung disease. And you can see the pattern of obstructive lung disease from 1998 to 2009. We are decreasing in those disorders due to reduced amount of smoking. During the 1950, this disease were a lot in community because a lot of people used to smoke, and there was not a lot of education about the effect of smoking. Okay. Respiratory system function. So respiratory system function is to exchange gases. That's what it does. Respiratory system brings oxygen to the blood and get rid of carbon dioxide from blood to the respiratory system. So here you go. So pulmonary artery divide and becomes pulmonary arterioles, which is coming from your right ventricle, and then it comes to the lungs. And in the lungs, it becomes capillaries. And these capillaries, network capillaries, covers the smallest unit of our lungs, that is called alveolus. So when we inhale oxygen here, and from our nose, when it enters this alveolus, then what happens? The oxygen in our air here is higher compared to oxygen in pulmonary arterial blood, because pulmonary arterial blood is venous blood. So it is blue, it has a lot of carbon dioxide. So here, oxygen from alveoli enters these capillaries and carbon dioxide from these blue veins exit and get into alveoli and then go back to your nose and you exhale. And oxygen then enters into the capillaries, and these capillaries then becomes red pulmonary venule because they are rich in oxygen. They join and they form pulmonary vein. We have 4 pairs of pulmonary vein which enters your left atrium and then left ventricle and then through the aorta. It sends oxygen rich blood all over the body. Okay. Function of the upper respiratory tract. So from nose to larynx is upper respiratory tract, and their function is they warm the air because nobody knows which time, what kind of ambient temperature is. So if there is hot, it brings your air to your body temperature. If it is very cold, your nose and pharynx put some temperature, heat, and increase the air. So it warms the air, humidify air, and filter if there is any dust particle. And then it also produces sound because larynx has the vocal cord which produce sound, and detect also a smell. Upper respiratory tract here, nose has the olfactory bulb here, so that help in smell. Those are the function of upper respiratory tract. You can see the upper respiratory tract organs here. Function of the trachea. So trachea is a tube which has outer wall of the muscle and connective tissue, and then there is hyaline cartilage, and then after the hyaline cartilage there is the submucosa which contains a lot of mucous glands, and then there is pseudostratified ciliated columnar epithelium with a lot of goblet cell here too. So both mucus and goblet cell produce some mucus which put into the cilia, and then cilia through the mucociliary escalator, they sweep the dirt which we have inhaled in the respiratory tract and brings it up through the ciliary movement. The mucus and the dust comes to your uh, trachea and then to the larynx, and then larynx cause irritation reflex, coughing reflex, and we cough and we expectorate, or sometime it does get into the pharynx and you swallow it. That's how it clean our throat. Okay. The tracheal wall organization. To trachea, you see trachea is made up of 20 hyaline cartilage rings, and these rings are incomplete. If you see posterior, there is trachealis muscle, which help in expansion and contraction, expansion of the trachea during breathing in and breathing out. Trachea divide into uh, primary bronchi, right and left, and then secondary bronchi, tertiary bronchi, terminal bronchioles, and ultimately respiratory bronchi and respiratory bronchioles, and then smallest is alveolar sac, and you tiny small white sac are the alveoli. And this is the alveoli, alveolar duct, where gas exchange takes place. Uh, in the respiratory bronchioles and other bronchioles, there are very, so you see from trachea to the respiratory bronchioles, trachea is losing cartilage and they have a smooth muscle in their wall. That's why bronchi and bronchioles can expand. And when you take the inhaler bronchodilators, these are the dilators which works particularly in this area where there is no cartilage and mostly muscles, smooth muscles. All the medication like bronchodilator, corticosteroids, they work in this area where there is less cartilage and more smooth muscles in the wall. And when it reaches the alveoli, there is no muscle. They have only the simple squamous epithelium and connective tissue. Okay. So that is the function of the respiratory tract. Like now the mechanism of breathing. So breathing has inspiration and expiration, or inhalation and exhalation. So how we breathe? The function of breathing is performed by two major muscles in between the ribs and diaphragm. If you go and check the diagram, so here, this is the diaphragm here, and let's go back and check the muscles. I will see that again. Okay. And the muscles in between the ribs, intercostal muscle. So external intercostal muscle and diaphragm, these two muscles. According to Boyle's law, if you keep the volume here, this is the volume, and here is the pressure inside, you see? So if we decrease the volume of this liquid, what happens? Pressure increases. If you increase the volume, then pressure decreases. So let's see, in our lungs, when diaphragm, it is the, this is during the rest. So you see, diaphragm is like slightly dome shaped, and there is intercostal muscles. These muscles are skeletal muscles. So when diaphragm contract, diaphragm becomes flat and it comes down from this level, it lowers down. And then when external intercostal muscle contract, the thoracic wall goes outward, and that's how you increase the volume of the thoracic cavity. And once you increase the volume, according to Boyle's law, what happens? Intra-alveolar pressure decrease from 760 millimeter of mercury to 750 millimeter of mercury. So that means pressure is decreased. That's why air is coming inside, and that is inhalation. So in summary, inhalation or breathing in is due to decreased pressure inside the lungs as a result of contraction of diaphragm and external intercostal muscle. That's why two major inspiratory muscles are the diaphragm and external intercostal muscles at rest. Yeah, so this is the diaphragm, this is the lungs and ribs, this is the structure just. So inhalation and exhalation, again, same thing. I'm here, inhalation. The muscles contract, the diaphragm contract, and then you have increased volume, decreased pressure, so air is coming inside. Exhalation, then what happens during exhalation? After muscle contract, then by normal feature, skeletal muscle relax. When it relax, it comes towards the center. So, and the diaphragm also relax, so it comes up. So you decrease the volume compared to rest, you decrease the volume of the lungs, and pressure increase. That's why air is going out, and that is exhalation. Okay, so exhalation is due to passive relaxation and recoil of external intercostal muscle and the diaphragm, which increase pressure inside, and then you do exhalation. Okay, so lung volumes, we talked about it earlier. Lung volumes are measured by spirometry, and these indicators are used to diagnose the function of the lungs and the diagnose disease, whether it is obstructive lung disease or restrictive lung disease. Okay, so some more disease, like if you have any lung disease, you will have abnormal measurement of these volumes, tidal volume and all other volumes. But there is another volume to differentiate between the disorders, whether we have the restrictive lung disorder or obstructive lung disorders. So the main feature in any restrictive or obstructive lung disorder, when the volume is decreased, that is restriction or restrictive lung disorder. When flow of air is reduced, that is obstructive, because there is obstruction to the flow of the air. So here in this graph, you see there is flow rate liters per second, and then here is expiration and inhalation. So let's see when you inhale in the lower graph. When you inhale, what happens? Initially, you are inhaling. Inhaling is denoted by negative. So you are taking in more and more and more volume. So at the beginning, you are inhaling faster. You rate. And then once you have inhaled, then what do? Later, what happens? It's slowly reduced. Okay. Then you exhale. When you exhale, at the first second, you exhale very fast. You see 90%, this is the time. 90% of air, what you have inhaled, you will exhale during first second. And then slowly exhalation goes down. So you have 25%, then 50%, and you reduced by 75% rate of exhalation here. Normal, you will exhale 90% of your inhaled air within first second, which is called FEV1, means expiratory force volume in first second, FEVN. Okay. So force expiratory volume or first second percentage FEV1 correspond to how much of the total volume of exhaled air that can is exhaled in the first second. A healthy respiratory system can exhale more than 90% of total volume in 1 second. If somebody has less than 70% this volume in 1 second, then we call it the rest, no, sorry, obstructive pulmonary disorder, like COPD. Okay. So differentiate between obstructive and restrictive disorder is FEV1 and the volume. Okay. So here, differentiate obstructive and restrictive disorder. So obstructive disorder has reduced flow, whereas restrictive disorder has reduced capacity. So force vital capacity, that means how much air you can exhale or inhale. That is normal in obstructive because it is only flow obstructed. But in restrictive, the volume is decreased, so there will be forced vital capacity low. Lungs move less than the normal amount of air. FEV1 1% force exhale volume in the first second compared to total exhaled air volume. So how much you exhale and how much you can exhale in first second of total percent. This is low, less than approximately 70% of normal air in obstructive, and it is normal in restrictive lung disorders. This is all again the same thing here. So you see here the flow in the normal individual and the volume in the normal individual. When it's obstructive, what happens? Initial flow, and then in first second, you see flow is so low. It is not going like flat curve. It drops and then very slow flow. And there is slight decrease in volume, but usually the volume is not decreased. In restrictive lung disorders, you see the volume is totally compared to this one reduced, but flow is still same percentage wise. This is obstructive disorders like the emphysema. So this is healthy lung tissue. You have simple squamous epithelium here in the alveoli, and you see damaged alveoli, and several alveoli are communicating with each other. That is called confluent alveoli. This is due to chronic bronchitis, asthma, and emphysema. Obstructive flow, low FEV1, low FE, FEV 25 to 75%. So all the forced expiratory volume is reduced. This is the restrictive disorder due to neuromuscular disorders. And this individual is taking inhalation medication through the nebulizer. So nebulizer contain bronchodilator, which open up the bronchi and bronchioles so they can get more oxygen. Obstructive and restrictive disorder history. Obstructive disorders have reduced case of flow of air, and in restrictive there is reduced airflow that is moved. And these are the disease which we have talked earlier. Causes is usually in obstructive like COPD, smoking, environmental allergies, regular dust or smoke, those things. And in lungs, you have lung elasticity will suffer. So there is like neuromuscular disorder or morbid obesity or any like fracture with the ribs or other problem with the ribs. This is understanding the graph and of spirometry. So here in this table, you can see normal tidal volume, inspiratory reserve volume, and expiratory reserve volume is 500, 2000, 100. And then we compare here. This one, inspiratory reserve volume is normal 2000, patient 2300. Tidal volume is normal. Expiratory reserve volume is 1000. Normally he has 900 ml. So looking at this graph, you can say whether the patient is suffering from obstructive or restrictive lung disorders. It's the same graphs, understanding the graph and diagnose the patient. Again, same thing we talked about earlier. And these are all the volumes again, normal, obstructive, and restrictive volumes given for the normal obstructive patient and restrictive patients. You can go over them. This is the patient histories and symptoms indicate the disease. So all the patient's history and their what are the other conditions of restrictive and obstructive disorders. Same thing here. So this is all about the pre-lab learning of the respiratory system and for your virtual lab and for the in-class lab, face-to-face lab. I have already posted the handout. Please go over them before you come to the lab on Thursday. Okay, thank you guys.